I want to welcome Dr. Anita Patel. She is a board-certified pediatrician as well as board-certified critical care doctor at Children's National Hospital in Washington, D.C. Welcome, Dr. Patel.
Thanks so much for having me.
Of course. And for those of you guys who don't know, of course, me and Anita are also very good friends in real life, as are many of the women who I've been interviewing. I'm lucky to have them all in my life. So today we're going to chat about multi-system inflammatory syndrome in children, also called MIS-C, which is associated with the SARS-CoV-2 infection. And it's something that we have heard a lot about in the news. And originally we didn't think that COVID affected children or affected them a lot less. And unfortunately, especially for people like myself and Anita, who are young moms and new moms, a little scary to hear all that stuff. So before we get actually into MIS-C, Anita, if you can tell our audience sort of how you got into pediatric critical care and what drew you to the field, and just a little bit more about you.
Yeah. So I always sort of knew I wanted to work with children. That was a very easy decision for me. What was not easy is I knew that doing general pediatrics, although incredibly rewarding and wonderful to watch kids sort of from age 0 on up grow up and take care of them in a clinic is wonderful. I knew that was not going to be quite enough for me, for lack of a better word. I really like using my hands. I like thinking on my toes. I like, really sort of energetic situations. And I also really like collaborative models of work. I truly went into my pediatric residency not knowing what I wanted to do after that. I knew I wanted to do something else though. And it was really in going through the different rotations that we do that I started to see a pattern in what I liked. So I did my peds residency at Cornell in New York. And as part of that, we do rotations at Memorial Sloan Kettering. And I really, truly fell in love with working with the patients at Sloan. I loved, obviously it's devastating to see children with cancer, but I was really touched with how incredible it is to be with families at sort of their hardest times. Right. And I was also struck with how incredible it is to not only take care of extremely sick children, but just I knew it would be rewarding to make them better. Right. I didn't realize that it would be equally, if not more rewarding, to also sort of help them in their last stages of life as well. And again, not to minimize, it's incredibly sad and it never becomes easy. But you realize that you can really do them such a service to give them an honorable death, to honor their wishes. And no matter what age they are, kids have their own preferences, their own personalities, and being able to cater to that was something that really touched me and made me realize that it was something that I wanted to be a part of. I wanted to be a part of families' lives during their most difficult times. So I actually applied for HEMONC, and it was very soon thereafter that I had my first rotation in the intensive care unit. And I then completely fell in love with that even more. It was sort of like working at Memorial Sloan Kettering, but on steroids, because it was just even more fast paced. And I got to work with my hands. I got to put breathing tubes in kids. I got to do, really interesting procedures, and you really got to see how every minute by minute action you took could help save their lives. And it was for all those reasons that I ended up going into pediatric critical care, and I never looked back. And I truly love it just as much as I did on the first day that I decided I wanted to do it. So it's definitely the right job for me.
Oh my God. I mean, I actually didn't know a lot of that about you. So that's like really amazing. You're really brave, because I don't think I have trouble putting eye drops in children's eyes. That's why I mainly do adult eye care. So when a kid walks in, I'm like, oh no, they're crying, I'm crying. Everything is a disaster. But no, I do treat some children, and they get good care.
Of course they do.
But no, that's amazing. And and now we're seeing, you are seeing this uptick of these COVID cases, and I can't even imagine what those parents feel like, because you typically take your child to the hospital to get better, and not that they're getting worse by any means, but now the hospitals are a scary
Our
place
scary place.
because
Yeah.
like that's why we're doing so much telemedicine,
Yeah.
because we don't want people in the hospital. And so, I mean, I guess let's just jump right in. What do we really know about MISC? And I know it's rare, right? So we can start there. It's not
Yeah.
very common.
Yeah, so I think starting with that is a great place to start. So it is very rare. We've had millions of cases of coronavirus in our country, and just over, from what I can gather, and this is truly emerging literature, so any numbers I give, just to give this caveat, are from reported cases. So there's likely more. But from the most recent literature search that I did, and it's currently, starting to be the end of June, there's been just over 200 cases in the United States. And if you think about the number of known COVID cases we have, and frankly, the number of unknown COVID cases we have, it's truly an incredibly tiny 0.000% percent of the population that has COVID that's getting this MISC syndrome. So a little bit of the history on it. It was actually first detected in England. So before we talk about MISC, I think it's important to talk about a syndrome that has actually been around since 1967, which is called Kawasaki disease. You're probably hearing it in the news referred to as KD, and that's Kawasaki disease. Now, Kawasaki disease is also very rare, but it's a common thing that we see in pediatrics, meaning you see at least a handful of cases every year. And by handful, I mean in your respective hospital, you'll see a handful of cases every year. And Kawasaki disease is a disease that is generally seen in kids less than 5, with a median age. So, although it's seen in kids less than 5, most kids are really less than a year old. And in Kawasaki disease, it's a very strange syndrome in that we don't have like a diagnostic test for it. So there's no swab to say, oh, you've got Kawasaki disease. It's actually a constellation of symptoms. So the reason why I'm talking about this, it'll make sense in a second, is that MISC shares a lot of characteristics with Kawasaki disease. So with Kawasaki disease, what we saw is that you have fever for greater than 5 days. And then you have a series of symptoms. So what are these symptoms? One is you have redness of your palms and soles, and also swelling. Later on in the course of the illness, you'll have often some peeling of your hands. You'll have what we call mucosal involvement. So your mouth has a mucous membrane. And what we see there is your mouth inside becomes really red. You get what's called a strawberry tongue, where literally your tongue looks really bright red and like a strawberry. And you can also get really dry, cracked lips. You can also get what we call conjunctivitis, your specialty, but definitely not mine. But essentially, you get redness of your eyes. You also get, the medical term is cervical lymphadenopathy. All that is we have lymph nodes in our neck, and they become very prominent or big. So you can feel lymph nodes on necks. And then one of the sort of scary things about Kawasaki disease, and why we pay a lot of attention to it, is because it is one of the consequences of it is about 20% of patients who get Kawasaki disease develop what we call coronary artery dilation. And essentially what this means is that one of the arteries in your heart gets a little dilated, and that can cause problems later on when you are an adult, and essentially it can predispose you to having a heart attack. So why am I talking about Kawasaki disease? So and I failed to mention this, Kawasaki disease is not directly caused by an infection, meaning, so when we are thinking about a diagnosis of Kawasaki disease, we actually ask, have you had viral symptoms within the last 2 to 4 weeks? Because Kawasaki disease does not happen when you have the virus, it actually happens after. And we believe it's because essentially what Kawasaki disease is your body develops a immune response. So, and it's an exaggerated immune response to the virus that had affected you a couple weeks ago. So it's not surprising now that we saw an uptick in what we initially thought was just Kawasaki disease from the SARS-CoV-2 virus. Now, it turns out it's not that simple, actually. So the first reports of this were out of England, and they were saying, we're seeing an uptick in Kawasaki disease. That was the first report. And then suddenly they said, guys, this doesn't look like it's just Kawasaki disease, because these kids are, number one, presenting with slightly different symptoms, which I'll talk about in a second, but they're also getting extremely sick. And what it looks like is it's not just Kawasaki disease, but it's a combination of Kawasaki disease and also toxic shock syndrome.
Oh.
Now, toxic shock syndrome is essentially a syndrome where you have a bacterial infection. Generally, it's caused by staph or strep. There is also a Clostridium strain that can cause it. These are just common bacteria that cause, essentially, they release toxins and make your body really, really sick, and you need to be in the ICU to be taken care of. And they were seeing sort of that these kids with Kawasaki were also showing signs of toxic shock. And it was this weird combination that seemed to be directly related to a prior infection of SARS-CoV-2. And that's where this MIS-C was born from.
So for anyone who remembers, toxic shock syndrome is also something that was very popularly talked about when a woman had left her tampon in too long. And so it's actually quite serious, as Anita mentioned. And, these patients having the combination of both could be pretty devastating to the child. Quick question. So because it's rare, right? Is it more rare than Kawasaki? Because I know Kawasaki isn't very common. I've seen actually a case of Kawasaki when I was a med student. So would you say, I mean, I know there's not a ton of data yet, but would you say it's more rare, or it's going to be more rare? Or
so that's really hard to say, because so Kawasaki can be caused by sort of a bunch of different viruses.
Okay.
So in that sense, let's say we weren't in the middle of a global pandemic, then I would say, yes, this MIS-C is definitely more rare, because we have such a large number of cases of COVID and SARS-CoV-2 infections. And although kids are not getting sick from COVID, we know that they are carriers for this disease and they have the virus. So I think it's really hard to say, is Kawasaki more common than MIS-C or vice versa? Right now, I think it's also just a matter of, there's no national registry right now for Kawasaki. So I actually don't know how many cases per year we're having of Kawasaki disease. I know in my hospital, we might, over the summer, it's more common. I feel like we see it generally in the end of the winter, spring, summer months. As I said, we'll see a handful, maybe 5 to 10, and we've seen much more MIS-C in a very short period of time. So I don't know if that helps a little bit, but I would say right now it's too early to tell, but we've seen a large number of this syndrome in a very short period of time.
I mean, it makes sense. We're in the middle of a pandemic, so of course there's going to be more. And it's also hard to tell because a lot of these kids get sick afterwards, so it's not, directly correlated. You're sort of seeing this time lag. And what can parents look out for? Like, even though it's rare, like, of course, every parent, I mean, I am so paranoid about my child getting that. What can parents look out for? Like, what's that line between, I need to go emergently to the hospital, or at least call my doctor? Like, where do we start?
So I think number one, this is such an incredibly stressful time for all parents. You know, I got sick last week. I was mentioning it to you, and just thinking about the idea of having, you know, any fever that any of us have right now, of course, our mind is going to, do I have COVID? So, what can parents do? So I think having a high index of suspicion for MIS-C is important. And I think getting the word, that's why the news media is getting the word out about it, because, you know, in that very tiny percentage of patients that do develop MIS-C, they have gotten very, very sick. Now, the good news is with the right treatment, and we can talk about that in a little bit, most of them have recovered. There have been a couple deaths, but I think now that we have such a high index of suspicion for this disease, that rate of having any deaths or having, I think that even those couple deaths happened early on when we didn't realize that this syndrome was happening. So you're back to your question, what can parents look out for? Number one, if your child develops a fever, obviously that's the first sort of necessary symptom that you have to have to develop MIS-C. Okay. So step one, and I always think of this as a stepwise thing. Step two, most kids are presenting with nausea, vomiting, and stomach ache. So if your child is developing nausea, vomiting, and a stomach ache, I would say another bell should go off. Do you need to absolutely go in? Not necessarily, but what I would say, particularly right now in the setting of the pandemic, is call your pediatrician. Okay. The other symptoms that parents need to look out for with MIS-C is their kids are going to be developing likely a rash. And then actually all the symptoms that I mentioned with Kawasaki disease. So they can have that red mouth, the dry cracked lips. They can get changes in their skin color. They can also get very lethargic or just act strangely. Mm-hmm. So, you know, what distinguishes MIS-C from Kawasaki disease? I already said the major thing is most of them are getting much sicker than kids with Kawasaki disease get. What is really sort of different about this MIS-C syndrome is that these kids are developing shock essentially. And so the idea with recommendations and the reason why we're getting all this information out is because when you're developing sort of the fever, abdominal pain, potentially a rash, potentially that adenopathy, those are signs that you should definitely call your pediatrician. I would suggest at that point getting tested. And at that point, what your pediatrician also might suggest is getting some laboratory work, because there is a very sort of common pattern of laboratory work that is necessary to also make this diagnosis of MIS-C. And they're all just common labs. It's not like a diagnostic test, but it's more of, again, a constellation of symptoms and labs that sort of tell us that you have MIS-C.
And what's like the time lag, right? So if my child has a fever, I mean, do I wait like a day for him to get all these other symptoms? You know what, like when do we see this constellation sort of present?
Yeah, so that's a great question. So in normal Kawasaki disease, we require 5 days of fever. And MIS-C, that's not the case. So it just requires 24 hours of fever. So what I would say, again, and this is very specific to this pandemic right now, is if your child develops a fever and keeps having that fever for 24 hours, at that point you call your doctor right now and you get tested for COVID. Now, one thing that's important to note is that these kids that are developing MIS-C might test negative for COVID on the nasal swab that we're getting. Now, most kids end up being positive on the antibody test. So I think we all sort of know this because we hear it in the news, but there's two different tests for COVID, right? There's the nasal swab, which is a quick test. And then there's the blood test, which tests for antibodies to COVID. Now, so a small percentage of these MIS-C patients are positive on the nasal swab. Again, most of them are positive on the antibodies. So the recommendation that we're giving to sort of the ambulatory or general pediatricians is that if kids are presenting with fever and even one of the symptoms that I just mentioned, the abdominal pain, lymph nodes, rash, etc., to then do the antibody testing and also do the other lab testing we test for white blood cell counts, red blood cells, and then markers of a pro-inflammatory or high inflammation state. And then if there's any of those symptoms that are positive, then they're sending them to the hospital. So again, if your kid, essentially back to your question, if your child has a fever for greater than 24 hours, call your doctor. I think that's the simplest thing to say, because we are finding that the earlier that we detect the syndrome, the better chances we have of catching it before the kids get really sick.
And what are some of the ways that we treat this for people watching?
So most kids are getting treated with something that's called IVIG, which is intravenous immunoglobulin, that we've always used to treat Kawasaki. We know Kawasaki is caused by your body having a lot of inflammation. And what IVIG does is essentially it goes in and sort of reduces all that inflammation that's going on in your body. So most kids with MIS-C are getting treated with IVIG. A small subset are also getting treated with some steroids. And then even smaller proportion of patients are getting treated with very specific drugs against cytokines. One of them is called anakinra, and another is called tocilizumab, which again, you may hear on the news right now.
Yeah, that's so they go to the hospital, they get tested. Are pretty much all these patients going to be treated inpatient, right? Because IVIG, all this stuff it's not like the typical COVID patient where it's, stay home, quarantine.
Yeah. So, and that's why, again, if you have a fever and any of the symptoms I mentioned, that's why if you're in a pediatrician's office, they're recommended now to do this whole set of testing, because if you are positive for MIS-C, you're immediately sent to the hospital or referred to the hospital. And once you get to the hospital, many of these kids are ending up in the ICU with us because unfortunately, once they start to develop the symptoms, they are getting sick fairly quickly, which is why, as all of us pediatricians right now as a whole, although it's rare, we have to have a high index of suspicion for it. And that's the good news, is that, the word is out in the pediatric community, and we really have been developing sort of standardized algorithms for what to test for. And that way we're not missing these cases. And for a parent, what that would look like, again, is you just see your pediatrician, you get these labs done, and if anything looks like it's remotely MIS-C, you are going to be referred to go into the hospital to start treatment. Now, the question about whether you end up on the regular pediatric unit or you end up in the ICU with me is based on how sick your kid is. It is important to know that about 50 to 60% of these kids are getting very sick. They're needing help with breathing, with a breathing tube. They might need medications. Yeah, they might need medications to help because their blood pressure is going really low. So we have to give them medications to help their blood pressure. And an even tinier percentage of these patients are ending up on life support. We call it ECMO. And essentially what that does is it is a heart-lung bypass machine. Again, the good news is most of these kids, even when they get really sick, once they start treatment, almost all of them are recovering. We have had a few deaths, but most of them are recovering.
Very reassuring. Obviously, as a parent, this is like someone's worst nightmare.
Yeah.
Before we sort of wrap up, just one last question. I know that this is probably not something that you can answer with any kind of, definitive statement, but just from your professional opinion, any characteristics, and I know this could even change in the next week, but any sort of characteristics that you see that you feel like, okay, maybe children with this are more susceptible, like with COVID, how everyone's if you have more comorbidities, you're more likely to get sick. Yeah. Anything that you're seeing, either a specific age group, because I've seen case reports that are, as young as, under 1 year old getting MIS-C, but then also I think I saw a 19-year-old. So obviously there's a huge range. So yeah. Any specific characteristics, either, age, race, sex, comorbidities, anything like that you would say maybe higher risk?
So comorbidities just do not look like they're a risk factor for developing MIS-C. So meaning for, a normal parent, if your kid has, another disease, it doesn't look like they're at any more risk of developing MIS-C. And frankly, Kawasaki in general is a disease of normal, healthy children. We do think that there is a genetic predisposition to Kawasaki, and there's likely a genetic predisposition to MIS-C. Unfortunately, we don't know what that genetic predisposition is, so we can't test for it. But it's not like COVID where we know if you've got, if you're obese or have asthma, et cetera, that you're at more risk. It's not the same. Unfortunately, we don't have those characteristics. What we do know is that it is in general affecting an older group of children. So I mentioned in the beginning, Kawasaki is really a disease of very young children. It happens most of the time in less than 5-year-olds, and even more often in less than 1-year-old patients. With MIS-C, we're seeing that the median age is 9. So it's really, if you're 9 to 10 and up, we're seeing it more commonly in those kids. And as you mentioned, there's a 19-year-old in the news. We've seen it in kids less than 21. And I have to be honest, and this is not based in sort of what's in a journal or in the news, but I suspect it's even happening in syndrome. You need to have a high sort of level of suspicion that the syndrome exists, right? There's no test for it. You have to look at all these symptoms. So it is definitely a disease of slightly older children. Now, you were asking about race. So Kawasaki disease is more common actually in persons of Asian descent. We're not seeing the same trend with MIS-C. In France, so far in the England study and also in the American reports, we haven't seen sort of racial or ethnic predilections yet. And in fact, we're not seeing it happen more commonly in Asians. In a study out of France, they did note that there was slightly higher incidence of MIS-C and if you had Afro-Cuban descent. Again, we haven't seen similar trends. It does appear to be slightly more common in males. Again, there's such a small population of patients that have developed it, so it's hard to say if that's real or not, but slightly higher percentage in males. Those are the only sort of underlying, I'm not going to even call them risk factors, but sort of associations that we've seen with MIS-C. And then the other, in terms of distinguishing it from normal Kawasaki, in addition to having them get much sicker in general, we also are noting that their labs, their inflammatory markers are much higher than in normal Kawasaki. So that's also sort of a distinguishing characteristic from a disease that we know well.
Yeah. Well, this was really enlightening, obviously some very scary things, but it's good stuff for everyone to know and to keep an eye out for. And just to sort of wrap everything together, if people had more questions about this or wanted to get in touch with you or connect with you, what's the best place for them to find you, either on social media or online?
Yeah, I think on social media, Instagram, you can find me at Anita K. Patel, MD. I'm very active on there. And, just sort of a closing remark, I know this is a really stressful time for parents, and, you and I are new parents, but I keep reminding myself that it's just about being vigilant. Again, luckily kids are, overall not being affected as much. And it's important to be highly aware of the syndrome, but also remind yourself that it is incredibly, incredibly rare,
Yeah.
So be vigilant, don't be scared.
Yeah, no, that's great advice. And I have to take more of your advice.
I do too.
All right. Well, thank you so much for spending time with us, and I will see you on Instagram.